উনি আমাদের সেকেন্ড রেসিডেন্সির।
সব পাস করার রিপ্রেজেন্ট করতে হবে না? পাস করারই
না, অনেকে আস্তে আস্তে পাস করা নেই, জুনিয়রও করছে না অনেকে, আফতাবজলে করতে পারবো। জুনিয়র মেডিকেল অফিসার মিনসের প্রেসিডেন্ট করছে কিন্তু
Thank you to the
অ্যালাউ করলে সবাই।
Bangladesh Society of Neurosurgeons for allowing me to discuss about this topic and paper. It is a single case actually, and I'm sorry I'm disappointing you, sir, but this is really a challenging one. Spinal arteriovenous malformation is a rare disease among vascular malformation of the spine. It comprises about 60 to 80% of cases whose etiology is not utterly clear. The clinical presentation and imaging findings may be non-specific, may be sometimes misleading, often mimicking other diseases like demyelinative one. So let's come to our patient, 24 years female, non-diabetic, non-hypertensive, presented with complaints of progressive decrease in sensation in right upper limb and below chest bilaterally for 7 years. She also complains of right upper limb weakness for 5 years. And on examination, tone was increased on the right side in upper limb, wasting of the arm, forearm, and small muscles on the right side. There was no fasciculation. Muscle power was 4 on MRC grade with weak hand grip on the right side. Pain sensation decreased below cervical 5 dermatome bilaterally, and temperature sensation was impaired. Biceps supinated jerk was impaired, triceps absent on the right side, and all other jerks were exaggerated. Plantar response was extensor bilaterally, lumbar test was negative. We did an MRI which shows, you can clearly see there is an extensive lesion in sagittal section. I'm going to the axial one, where this extensive lesion, which was extended from cervical 7 down to T3, there are multiple flow voids situated in intracanal and outside that canal, extraspinal or paravertebral area. So based on the MRI, it was at the clinical radiological examination, we thought it might be C5 to T3 extradural compression, and we went for angiography. This angiography shows it is definitely a spinal vascular malformation. We use left transradial approach, and in the same setting we try to embolize, but with the Onyx one. You can see the embolization procedure. The features were from bilateral cervical part of the vertebral arteries, left costocervical arteries, right internal mammary arteries, and bilateral T2 to T4 internal intercostal arteries. So we tried to embolize as much as possible. The patient was managed endovascular procedure. Post-embolization angiogram showed complete operation of feeders from intercostal arteries, but persistent feeding was there from left subclavian arteries, and post-procedure period was uneventful. So patient was advised to embolize after 3 months. After the initial procedure, patient was as improved. She visited 3 to 4 years later, and we did the angio again. We can see on the left side, this is earlier embolization, but on the right side, there is another AVM, vascular malformation. And after the procedure, patient developed a swelling in the right supraclavicular area, which was pulsatile, free from skin and underlying structure. Initially, it was non-tinted. So we thought about planning a hybrid surgery, as my earlier speaker said, we tried to embolization procedure, and later on dissection about the right supraclavicular area. So during this procedure, we tried to embolize again as far as possible, but there was rapid shunting of blood. So we put a covered stent to divert the flow. But the difficulties were the covered stent that we had, the diameter of the vessel was much greater. So we did balloon expandable covered stent here to bypass the vessel, to bypass the flow. Then when we were checking that it should suffice or not, we see there were still areas from where the blood can flow. So we put stent and wiring to occlude the remaining area. So this is the post procedure, which shows the flow diversion was successful. And after this procedure, we operated on the right supraclavicular area, and we found clotted blood that was probably due to rupture of that AV fistula. After the procedure, neck swelling was subsided and the patient improved significantly. Till that follow-up, her muscle power increased in right upper and lower limb remains static to 4/5, and no sensory abnormality exists. So vascular malformation of the cervical spines are exceedingly rare, and to date there have been no large case series. And we know there are various varieties like extradural, intradural, and some complex vascular malformation. But this case is very challenging. Why it was challenging? Because we see in some articles there are clinical and angiographic characteristics of the spinal vascular malformation of the cervical spine. It shows patient may present with myelopathy, sometimes subarachnoid hemorrhage, sometimes subpleural hemorrhage. And the treatment, there are various options like conservative endovascular surgery or hybrid. In our case, first we noticed in the left side there is subclavian AVM, and later on the right side. So this is known as spinal metameric AVM, more complex one. Just a few glance about the metamerism and segmentation. During the 32nd day of our gestation, there is a formation of somites and segmentation. We have 33 segmentation. From the upper 3 segments, our head develops, and from the rest of the segments, there are 7 tissue develops like skin, ectoderm, mesoderm, endoderm, neurotome, and enterotome. These all 7 tissue develop from a single segments or metamer. So when there is abnormal segmentation in this metamerism, there is involvement of the nervous system, skin, muscle, bone. In this case, the vascular involvement of the both sides was involved, and this is termed as spinal metameric AVMs. Earlier it was known as juvenile AVM, but juvenile is a term which occurs or present as later stage, and it is confusing. So it is termed as metameric AVM. So in conclusion, spinal tuberous malformation, especially metameric AVMs, are extremely rare. But why we neurosurgeons deal with this type of AVM? Because these patients occasionally may present with neurologic deficit, and we must have a detailed plan whether we should treat it through only embolization procedure, or we need surgical, or we need both. Thank you.
Thank you, Dr. Mahendra Shagar. I want to make a question that this AVM is having two parts. And one is in spinal and other is extra spinal part. You have managed on the extra spinal part. You also mentioned that patient develops neurological deficit due to the AVM compressing the spinal cord. So, I think that in this case, you have presented exceptional one, but I think in case of spinal AVM, you should without removing the spinal part, patient may not improve. Most of the cases, patient will not improve. So, when you try to manage the spinal epidural AVM, you should remember that some AVM may be epicostillar to medulla. It is another one thing. Another thing, after surgery, do you have any post-operative MRI that is status of the AVM?
Sir, yes, sir. I have a post-operative MRI, but not right now in my computer. Anyway, so thank you for your question and suggestion. Our concept is in this AVM, why there is involvement of neurological deficit. It is because of the retrograde blood flow into the spinal cord, which is causing ischemia.
Some cases, when you embolize or you remove the extra spinal part, stagnation of the AVM where that compresses the spine knee complex or knee different. So I think after embolization, you should remove the spinal part. Thank you very much.
Any question? No. Thank you, Dr. Human Rashid, for a nice presentation. Our next speaker, Dr. Mohammed Samsul Arifi.